HPK1 is a really interesting target. It's an immune modulator target. In a way, it's almost like a checkpoint, but within the cell. So what it does is when HPK1 is active, it basically decreases T cell activation, but it also decreases activation of other important immune cells, B cells, and actually dendritic cells as well. So overall, it really suppresses an effective immune response. And a lot of preclinical studies, mouse studies, where they can just genetically delete that HPK1 has shown that if they do that, the T cells are more active, the B cells are more active, the dendritic cells are more active, and in a mouse, it really is more effective at clearing cancer. And so this really sort of nominated this as an important candidate to be able to maybe therapeutically inhibit in order to improve immune therapy. The difficulty is HPK1 is part of a family of kinases, MAP4 kinases, that are very, very similar in terms of their structure, but have very different roles. So some of them, like HPK1, block the immune response, but others are actually immune activators. And so you have to come up with a drug that's very selective, because if you just inhibit that entire family, you're going to cancel out your effect. And this drug, NDI-101150, is a really specific HPK1 inhibitor. And so the idea was this really intriguing preclinical data. Does this actually translate into people in a very treatment refractory setting? This is an area of tremendous clinical need. Once a patient has progressed on an anti-PD-1 therapy, there really aren't other immune therapy strategies that have been shown to be effective. So a huge area of unmet clinical need. And so this was a patient population that was really refractory, a median prior lines of therapy of 3, where we tried this new immunomodulatory approach by inhibiting HPK1. And I think encouragingly, we really do see responses, specifically in clear cell renal cell carcinoma. There's one patient who had a complete response, 2 patients who had partial responses, and then 3 additional patients who had stable disease, but that was really durable. One of those stable diseases lasted for about 25 months, so over 2 years. And so there's clearly clinical activity of this drug, even in a refractory space. And it's one that also showed responses in a lot of different kind of tumor biologies. The patient who had a complete response had been on only 2 prior lines of therapy, and each one worked for a long amount of time, had been on a TKI for a while, an anti-PD-1 for a while, and then progressed. But some of the other patients who responded were essentially refractory to anti-PD-1 therapy, never responded at all. And so it's actually really encouraging to see that it's not just one sort of subtype of patient, but across multiple different kind of patient trajectories, we saw clinical activity of this drug. I think we need to expand it to a larger number of patients, exactly what you're saying, in sort of these larger phase 2 trials. And I think there's 2 strategies to do that. The majority of the trial was monotherapy, and that's where we saw the responses. But there were a select subgroup of patients who were treated actually with combination of this drug, this HPK1 inhibitor, together with pembrolizumab, the anti-PD-1 drug. None of the patients with kidney cancer, but across other solid tumors. And that was really a proof of concept that was safe to combine, and it was. We didn't really see any new safety signals. And so I think that actually opens up how this might be sort of brought forward clinically. One is the more conventional path, which is to develop it by itself as a monotherapy in a pretty treatment refractory setting and start from there. But the other, knowing it can combine well with other immune checkpoint inhibitors and to do so safely, is to start to move it earlier in the treatment cycles to really see, can it add to existing immune therapies and improve our durability, improve our hopefully our cure rate ultimately.